country. And that's okay. First of all, I want to excuse me because I discovered what was the time of my presentation just the day that I was arriving, because I wasn't receiving the program before. Maybe my presentation is longer. I try to do my best to run shorter. When you think that I need to stop, advise me and I'm stopping. Okay, just to tell you some historic thing about, but very short. The first one that was describing in a man adrenalectomy was Michel Gagné in New England Medical Journal, and Higashihara in Nippon blah blah. And of course 600 cases was on this first years, and of course the advantages to mean-invasive approach are always enhanced recovery, shorter hospital stay, and cost effectiveness of the laparoscopic approach to this pathology. And okay, I doesn't want to lose time, but it's very similar, the adrenalectomy to the cholecystectomy, because we have a vascular pedicule, we haven't really that, but it's something that is ablative surgery. You have a piece to take out more frequently for benign disease than malignant. And okay, cholecystectomy can be the first step to go safely to the adrenal, because it's not so difficult surgery. Other historic things that are not important, and I want to speak also about my comparison with robotic approach compared with laparoscopic approach, because in our vision, robotic has some advantages. Of course, the disadvantage is the cost and the difficult to maintain this equipment that is very expensive today. But the three-dimensional optics, the surgeon view is magnified with excellent resolution and its perception. It's a very fantastic view that you can have inside this monitor that you have in your eyes. And robotic instruments have also, as you can see also yesterday, this wrist that offers 7 degrees of freedom, filter every kind of tremors. This experience of every one of us, that after 4-5 hours working with the arms suspended, tremor is starting to appear not only on my arms that I'm an old man. It's a fatigue effect, and for this we have a filter inside the robotic equipment that eliminates every kind of tremor. And it's important for a very precise surgery and allow precise movement. The surgeon has a control of a static camera, 2 operating robotic arms, and optional 4th arm, which can be used as a retractor, especially to the right side, when the liver is covering quite completely the adrenal gland. And ergonomically designed robot station maximize the surgeon comfort. Not to maintain surgery comfort, but just to let him to be more precise. Okay, the key points I want just to resume. The learning curve is really demonstrated today without discussion. Learning curve for young surgeons that are starting advanced laparoscopic surgery is shorter than the homologous learning curve by laparoscopy. We have not argument to explain why, probably because the next generation, that is connected generation and technologic generation, have more feeling with this equipment than going, having our experience first in open and then in laparoscopic surgery, as you know. At the start, of course, the operating time is longer because it's not the problem only of the surgeon, but all the team must to take confidence with the installation of robot. It's a docking time that takes time at the start, but today in our experience is quite the same time. Because also adrenal frequently is a short operation, speaking about time. Costs are really unbelievable till today, because only one company is leader in the market and only one robot you can buy, and for this reason the prices are decided from the company. But we know that in this year probably 2 new robots are coming on the market from leader companies like J&J and Covidian Medtronic today. Probably the advent of this new robot is dropping out down the prices, and probably the diffusion of this equipment can be more elevated than today. We can do also without, of course, we can do without, because doesn't exist surgery that you can do only with robot till today. Maybe it's just more difficult, the learning curve, but you can learn, you can do, no problem. It's not a limit for every kind of surgery. And maybe robot is more useful on difficult cases for adrenal. It's very nice also for the retroperitoneal approach, that it's more common for urologists and not for general surgeons that usually are going for transperitoneal. We can compare the advantages from of one or the other way to go, and we can do with robotic, but also, of course, with laparoscopy, sparing pieces of glands, especially in case of pheochromocytoma, of bilateral tumors that we can we need to take out, determining a very strong dependence from the corticosteroid therapy for the patient that is going to have bilateral adrenalectomy. And especially this approach is more and more easier for obese patients. We know, all of us, that a lot of surgical procedures are better by an invasive way to treat obese patients. It's not important there. We can have different positions on the table: lateral decubitus, supine decubitus, or prone decubitus, totally prone decubitus. And we can have also, I can say before, transperitoneal or retroperitoneal approach. Transperitoneal approach, that is what the major part of the general surgeons are using, request, or for us is better, but 80% of surgery is going by this way, lateral decubitus, totally lateral decubitus. We think that lateral decubitus give us possibility to have better view of anatomical landmarks. It's feasible also for big size masses, sometimes happen, and it's a very good exposition of the operative field. What is the only real big contraindication for lateral position? If you need simultaneous bilateral approach to both adrenal glands, and also in case of heavy previous abdominal surgery, can be more difficult to go as for every other kind of intra-abdominal pathology. Position of the trocar, you see to the left side, can be enough to use only 3 trocar with laparoscopy, and to the right side, it's usually mandatory to use 4 just because you need to add liver retractor to the right side. Robotic requests more trocars. First of all, because robotic doesn't have possibility to have all kind of instruments that we are using routinely. For example, doesn't exist stapling for robotic till today. And also because we need one port to introduce something like suction, simple suction, that is not connected with the robotic side. For this reason, we have more trocars for robotic placement, as you can see. And finally, we start comparing on the same screen robotic to the left side and laparoscopic to the right side for the right adrenalectomy. What is the first step? First step is to be able to disconnect opening working? I'm trying. Okay, this one. To open the posterior peritoneum just to be able to lift more the liver, dividing all the peritoneum on this subhepatic area. And you see that we can do by hook in robotic approach. We can use the hook also in laparoscopy. On this case, you can see that we are using radio frequency like ligature instrument, but it's not mandatory. You can do also with more simple instruments. And you can see to this side by robotic that we start from up to down. In this case, it's not mandatory and it's not a strict rule to go. We decided to go directly on the anterior part, searching for the first important landmark, that is inferior vena cava, and following vena cava, you can find the origin of the median adrenal vein. That is the only vessel about adrenal glands that you must to ligate or to clip. All the other vessels that exist, small artery, small vein, you can cut using coagulation, bipolar, monopolar, or more sophisticated and expensive instruments that we know. You see, vena cava is here, and pushing the adrenal gland laterally to the right side, you can try to improve the space between vena cava and the gland just to be able to identify the vein. On this case, you see by laparoscopy, vena was identified and we clip. Sometimes if it is not so big, you can also closing with the modern instrument coagulation and cutting that we can see to the right side. And after that, when the vein is ligated, procedure is quite finished. You must just surround all the fatty tissue on the superior pole of the vein, taking out the gland, not only the gland, but all the fatty tissues that it's surrounding, using which kind of instrument you want. Oops. Sorry. Okay. What about the left adrenal? This screen that you see surrounded of black is the last edition of the robotic screen with all the information on the screen, also for the team. And in my opinion, by robotic or by laparoscopy, usually left side is more difficult. Why is more difficult? Because the gland is put deeper than to the right side, and you need to search a lot to identify, as you saw yesterday from Michaela Piccoli from Modena, because to find the landmarks you need to move the spleen to the medial part, you need to open largely the peritoneum like on this place, and the only first landmark that you can find is to the splenic side, the tail of the pancreas and the splenic vessels, or the diaphragmatic vein, when you can see, can help you to go to the renal vein and then to the adrenal vein. You can see to the side of laparoscopy that was isolated and clipped, and we are doing the same, and this time is more synchronous to the side of robotic. And finish this time, the time of dividing the gland from the superior pole of the kidney is the same, of course. We need to put every time in the back okay. Drain or not drain, we can discuss. Usually we doesn't put the drain because this field remain very dry and no problems. You see what Michaela was showing us yesterday, this diaphragmatic vein that we can spare if it is possible. Sorry. This. Okay, thank you. Go. Can you touch, please? Sorry. This one, that's okay. That you can spare on this way, and the vein is remaining down, just clipping the adrenal. Going? Okay, I'm sorry because my statistics is just arriving to 2013, but unfortunately I was losing the numbers of the activity starting from the for the 2013, but I know that from 13 we have 150 more patients. It's a big number, and you can saw yesterday that it's not only surgeon that is doing the surgery in my department. Today is some routinary surgery that we do currently, also to teach the residents before they finish his residency in our hospital. Okay, it's not important about indication, it's the normal pathology that we know. Of course, pheochromocytoma, especially if it is strongly functioning, requests a special preparation for the patient, but it's not the same that we know for open surgery, because manipulation from robotic or from laparoscopy is less, and for this reason the incretion of catecholamines during the procedure is less, and the anesthesiologist can control better than when it was our open experience in past. Indication not important. Size. Exists a limit of size, because if you are reading what was produced in literature in past, they said at the start till 5 centimeters and then till 70. No, doesn't exist limits. It's depending from the experience and from the learning curve. The only contraindication is carcinoma or malignant pheochromocytoma when the CT scan is demonstrating some infiltration of surrounding organs or of the abdominal wall or of the liver. In these cases, we decided first to go directly by open surgery, or making maybe laparoscopic exploration that confirm what was the idea. But today CT scan can give you exact strategy that it's better to show. Of course, robotic was growing following our experience and the pricing of the robot. I want just to conclude my presentation. I think that robotic approach to adrenal surgery achieve good short-term outcomes and could be considered a valid option for the treatment of adrenal masses, with the potential to expand the limits of minimal invasive surgery, cause what we have presented before. Thanks a lot for your attention, and excuse me for just a longer time.
Thank you.